Okay, so today we'll be talking about depression and its management. I think you must have heard of depression. It's very common. So, what is depression? Low mood. People come to you when they say they have a low mood or they are sad, then it's called that they may be in depression. But depression is a syndrome. It's not just a lot of times what happens, we'll be talking about it, that the real patients of depression sometimes they don't get diagnosed, they're not coming to the services, or there are inadequate services available for them, and sometimes the people who are not supposed to be diagnosed, they get diagnosed with depression and they get antidepressants, and it happens usually at the physician's level. Psychiatrists won't be misdiagnosing because it's very easy to diagnose, but physicians often, they misdiagnose. Anyway, so we'll discuss in this presentation. We'll be talking about introduction to depression, epidemiology, the economics of depression, physical functioning, biological basis of depression, etiology, classification, depression as a syndrome, then biological or endogenous depression, clinical features, assessment of depression, drug-induced depression, comorbidities, course, and outcome. Introduction. Globally, estimated that 5% of people suffer from adult depression. A leading cause of disability worldwide. And it's not only the low mood which is there, it is actually people lose their interest in the pleasurable activities. They reduce their socializing. And there are problems with the sleep, with the appetite, with energy levels, with sex drive. These are usually called vegetative symptoms, biological or endogenous depression. These are the more affected areas, the four particular these areas. Now, there are known effective treatments for mental disorders. More than 75% of people in low and middle income countries receive no treatment. Barriers to effective care include a lack of resources, lack of trained healthcare providers, and social stigma associated with mental disorders. This is in general, not only about depression, in general, the mental disorders. There's a lot of stigma involved, and people won't come out. Now, this is reducing. Some of them are definitely talking about their depression. Yes, I was depressed for such a long time, and then I took treatment, and this way people should come out. At least those who are celebrities need to come out. A lot of celebrities suffer from depression, or even schizophrenia also. These days schizophrenia, they are very well treated. So if people, they come out with how they got treated, how they became productive, then I think there'll be some reduction in stigma, and more persons who suffer from mental disorders, they will be coming for the treatments. In countries of all income levels, people who experience depression are often not correctly diagnosed, or others who do not have the disorder are misdiagnosed, that I told you. WHO ranked depression as fourth most urgent health problem worldwide. Lifetime prevalence is 7 to 17%. Usually it is said 10% prevalence is there. So 1 out of 10 people, they suffer from depression in lifetime, which is very common. 15% of depressives commit suicide. That's also very important. 50% depressives do not reach for treatment. 25% inadequately treated. And only 25% get adequate treatments. WHO worldwide estimated 3.8% of the population is affected, including 5% among adults and 5.7% among adults older than 60 years. Now, here you can see during the lifetime, 1 in 8 persons may require treatment, and in any year, 1 in 10 persons of depression, they attempt suicide. Now, the risk factors: women, young age, lower socioeconomic status, separated or divorced, positive family history of depression, early parental death, negative stressful life events, chronic stresses, absence of confidence, being urban. Depression common among stroke survivors also, and their caregivers also. And depression is an independent risk factor for ischemic heart disease as well. The cost of either treating or not treating depression. When the treatment goes on, is the medication which will cost, the physician's visits will be there, and psychotherapy, if it is done, that is also a costly thing to do. And cost of not treating on the state: increased morbidity, increased mortality, decreased productivity, increased suffering by friends and family, chronicity of the illness, impaired personal relationships, and greater utilization of medical resources. So you can see it is much more if it's not treated, right? Now, this is about physical functioning in depression and other chronic illnesses. It's the predicted or adjusted mean score of physical functioning. In advanced coronary artery disease, 65.8% are functioning. With angina, 71.2% are functioning. Depressive symptoms, if a patient has, then it is 77.6% they are functioning. With back problems, 79% are functioning. With arthritis, 80.6% functioning. With diabetes, 81.5% functioning. With hypertension, it is 6.4% functioning. And with no condition, when there is no condition there, then 88.1% are functioning. This is the biological basis of depression. To summarize, we have monoamines which are deficient at the synapses. The monoamines are norepinephrine, dopamine, serotonin. Then there is another biological basis which is at the receptor level. It's abnormally upregulated receptors. So when the monoamines are less, then the receptors get upregulated. They become more sensitive. Because it is less, they have to become more sensitive. And to produce the similar effect which with normal monoamine level, these receptors will be producing. So both upregulation and deficiency of monoamine at the synapses leads to depression. Etiology, psychosocial factors, negative life experiences, more stresses in females like menarche, menstruation, pregnancy, childbirth, menopause. Although I've not counted, but there are in males also. But still, the statistics all over the world says that it's more common in females, the depression. A lot of times it gets divided into two, in the sense that the depression in males is not visible because a lot of them they turn into alcoholics. So that is another area which is important. The classifications: depressive episode, mild, moderate, or severe, with or without somatic symptoms, and when it is severe, it is with or without psychotic symptoms. Similarly, recurrent depressive disorder, mild, moderate, or severe. And then we have bipolar affective disorder, when currently it is a depressed state, it's again mild, moderate, severe. And then course modifiers like postpartum onset or seasonal affective disorders. So they are the course modifiers of depression. Now, depression syndrome, there are vegetative features like sleep, appetite, weight, sex drive that I told you. The sleep, appetite, and weight, they are either increased or reduced accordingly. To summarize, they are said to be altered, all of them, in depression. Cognitive features like attention span is defective, memory becomes poor, negative distortions are there, then impulse control is affected and leads to suicide or homicide. Behavioral features like motivation is very less, they don't participate in pleasurable activities, interests are reduced in various things, fatigability is there, energy levels are very much reduced. In the physical symptoms like headaches or stomach aches or muscle tensions, all kinds of somatic preoccupations are also there with depression. Now, biological depression, at least 4 of the following should be there: the loss of interest or pleasure, early morning awakening, depression worse in the morning, definitive psychomotor retardation or agitation, marked loss of appetite or loss of weight, excessive or inappropriate guilt, and then loss of libido. These are mostly the biological features of depression. When these features are there and usual onset around 40 years plus minus 5, you can say, then it is called endogenous depression. The other type is reactive depression, when it is more related to the stresses or to the other affairs of the person in general, as we talked about earlier. With psychotic symptoms, it becomes a severe depression with psychotic symptoms or psychotic depression. You can call it either way. And the psychotic symptoms are usually paranoid delusions or nihilistic delusions. You know about delusions? Definition of delusion also you must be knowing. And nihilistic delusion, you know, when a person believes as if things don't exist, you know, nihilistic. Sometimes maybe they believe that my brain is there, but it is empty. Maybe there is sand in my brain. Instead of the brain tissue, it is a sand. So that's nihilistic. Or the world doesn't exist. That also can be considered. So those kinds of delusions. Then the hallucinations, auditory or olfactory hallucinations. And in depression, when hallucinations are there, they are usually mood congruent hallucinations. Mood congruent means when a person has hallucinations which, themselves they'll talk about depression. So it's like you go and kill yourself, that kind of hallucination. So instead of having a suicidal idea, they're having suicidal hallucination. Or they'll be listening to the shouts around, a lot of people are fighting, and maybe they're listening to the derogatory voices, they're abusive voices. So those kinds of hallucinations. Similarly, olfactory, also bad smells, that kind of hallucination. Then there are bodily symptoms, anxiety symptoms, and social behavior, of course, withdrawn, agitated, those kinds of behaviors are there. Now, this is about mild, moderate, and severe, I told you earlier. Assessment of depression. This is a scale. It's a prime MD scale, it's called. And various symptoms are there, where usually it is seen over 2 weeks. When the diagnostic criteria also use, like in ICD-10 is one of the diagnostic criteria we use, then it is seen over 2 weeks. Most of these symptoms of depression, whether it is low mood, feeling of sadness, or there is reduced energy level, or reduced sexual drive, or reduced interest in pleasurable activities, or reduced socializing, all these symptoms, most of the times during the 2 weeks, if they are present, then they are diagnosed depression. So this is separately, I can give you this scale. We won't have enough time to go with each and every item there. Okay. And that differential diagnosis, drug-induced depression is very important. So whenever the drugs are used for various other purposes, then you must be aware of this, that, okay, what drugs can cause depression? Because sometimes it's a drug-induced depression. Like propranolol can cause depression. Clonidine can cause. Digitalis can cause. Alpha-methyl dopa can cause. Reserpine. They're not very frequently used, these, but propranolol, as you know, is a very frequently used compound. Analgesics, ibuprofen is frequently used. It is less used now these days, but in children it is still very much used. Indomethacin, then the opiates, various neuropsychopharmacological agents, amantadine, antipsychotics. Your risperidone can cause depression. Sedative hypnotics, bromocriptine. Then steroids and hormones, they can also cause depression. Various oral contraceptives can cause depression. Antibacterial and antifungal agents can cause depression, like ampicillin, cycloserine, metronidazole, very commonly used. Nalidixic acid, nitrofurantoin, streptomycin, they all can cause depression. Cimetidine, disulfiram, acetazolamide. So you have to be mindful, when a person is on various medications, then you have to see that if it is not causing depression, if a patient comes with depressive symptoms, then you need to look at the medications also, what medications they are already on for various problems. Physical diseases. In cerebral stroke, depression is very common. With Parkinsonism, it is common. With hypothyroidism, it is common. With various chronic diseases like hypertension, diabetes, coronary artery disease, arthritis, asthma, cancer, AIDS, etc. All of these can have a comorbid depression, can cause depression actually. Grief, Sometimes it is a normal grief which resolves within few weeks or months if it is a very near relative. But then if it doesn't get resolved for more than 6 months, then maybe it is, leading to depression and atypical grief. Then various psychiatric disorders like schizophrenia can have secondary depression. Initially, the schizophrenia is full of delusions, illusions, and disorganized thoughts, disorganized behavior. But once they get well, they come to the realization that, oh, we were having all these hallucinations or illusions or delusions, and it is a disorder and a very serious disorder, and then we have to take treatment maybe for the whole life. Then they start to feel depressed. So that's how it leads to secondary depression. Similarly, dementia can lead to depression. Alcohol and substance use disorder, whether it is they are trying to suppress the depression and take alcohol, or it is associated. Those things are not very much clear. Then various anxiety disorders also have depression associated. OCD also has depression, phobias also. These are other comorbidities with depression: generalized anxiety disorder, panic disorder, phobic disorders, obsessive compulsive disorders, alcohol and substance use disorders, physical illness, both systemic and cerebral illnesses. Now, the course and outcomes starts usually before 40 years of age. Duration of one episode is about 9 months. High relapse rates immediately after recovery, or more episodes are associated with relapse. It's five-fold greater risk of disability than normals. Number of days in bed was significantly greater than hypertension or diabetes or arthritis. 50% recover during first year of treatment, 25% recover during the subsequent years of treatment, and 25% less likely to recover. Slow onset with psychotic symptoms, again less likely to recover soon. It's a bad prognosis. Comorbid dysthymia, again a bad prognosis. Most of the mental disorders with insidious onset or slow onset, they have a bad prognosis. An acute onset illness, they have good prognosis. The outcome, the depression to the normal mood, 1 year, and then later 40% recovery remains there, 20% go into dysthymia, and another 40% stay depressed. That's the outcome. Dysthymia is a subgrade of depression. It is like most of the symptoms of depression are there, but they are subgrade. So most of the time they are having low mood, although they'll be functioning. It will be better than the cases of depression. Similarly, they won't be as bedridden as true cases of depression, and they'll be mobile, they'll be socializing also. It is reduced, but not to the extent as it is in depression. Their interest in pleasurable activities reduced, but not to the extent as is depression. So most of the symptoms of depression, they are less intense. That is dysthymia. And usually, sometimes it's difficult to diagnose depression and dysthymia. And usually, hence, also to diagnose dysthymia, these kinds of subgrade or low grade symptoms, they have to be present for 2 years at least, 2 years or more continuously. Then you get the diagnosis of dysthymia. Okay. Here the response. With the medication, 67% are responders and 33% are non-responders. And usually it takes 8 weeks. If the responders, you can see, so within 8 weeks, 67% they respond. Now, why adequate treatment is essential and early treatment is essential? When untreated, a major depressive episode may last on average about 9 months. Remits with treatment in 70% of individuals within 2 years of the first episode. At least 50% of the depressives will recur. Recurrence within 3 years increases to 70 to 80% if no preventive treatment is given. Initial episode may evolve into discrete and recurrent episodes. Each new episode brings new risks and chronicity and disability and suicide. So hence treatment is must, essential, as soon as possible. Now the dilemma is no increase in efficacy of antidepressants, 60 to 70%, despite introduction of various antidepressants after tricyclic. First of all, the tricyclic antidepressants, they were, must be knowing, imipramine, amitriptyline, all these are tricyclic antidepressants. But because of various side effects associated with tricyclic antidepressants, the later ones became more popular because of lesser side effects. But efficacy wise, there's not much change. Sometimes the tricyclics are more efficacious. Okay. One has to see safety to choose an antidepressant, the tolerability, the efficacy, economy of it, the price, and the simple administration, whether it is just a tablet once in a day or 3 times in a day. So the simplicity of administration. And these are the various antidepressants evolved. First, tricyclic antidepressants, then monoamine oxidase inhibitors, irreversible type or reversible type, then serotonin specific reuptake inhibitors, which are specific to 5-HT, then bupropion, which is norepinephrine and dopamine specific, then venlafaxine, reboxetine, nefazodone, mirtazapine, which is multi-receptor. Onset of action of antidepressants within weeks. Side effects within hours to days. Synaptic effects within hours to days. But therapeutic effect is 1 to 6 weeks it takes. There's no ideal drug. 60 to 70% patients respond to any drug given in correct dose for 6 to 8 weeks. And one has to try a drug with a previous history of response in patients or the family history of response. Sometimes there's a family history of depression. So you ask if any particular drug, SSRI, for instance, was effective in previous history or in the family history, then give that only. Suicidal tendency if present, due importance to be given to choosing, like tricyclics are never chosen with a suicidality because they have a lot of cardiac side effects and patient, if it takes overdose, would be dead. Check for concomitant diseases, their treatment, and the drug interactions. Now, tricyclic antidepressants still preferred uses in chronic pain, fibromyalgia, migraine, and sometimes as sedatives and hypnotics, then in severe depression. In the first four, they're used in low dose. But for severe depression, they have to be used in high dose. These are the least preferred uses of tricyclic antidepressants. I told you most of them. Now, one who cannot tolerate, then with urinary retention or with constipation, don't use tricyclics. Overweight patients, again, not to be used. Suicidal patient, not to be used. Patient with cardiac illnesses, not to be used. Then patients taking multiple concomitant medications, tricyclics should not be used as they have a lot of interactions, drug-drug interaction. Then patient with dementia also, tricyclics should not be used. SSRIs, they're the most safest, first choice of antidepressant in the whole world at this moment. Equal efficacy in comparison to tricyclic antidepressants. Then SSRIs were better tolerated than tricyclic antidepressants in two meta-analyses. They are good tolerability, and they are also efficacious in comorbid disorders like OCD, panic disorder, bulimia nervosa, and the least preferred with when the sexual dysfunctions are there, or when nocturnal myoclonus is there, or with consistent insomnia, then secondary refractoriness of patients, then comorbid physical illnesses are there, and GI side effects are there. Then the SSRIs are least preferred because they have all these side effects. These are the various doses of common SSRIs. Most commonly used sertraline 50 to 200, and average on an average maintenance is 100 milligram. Fluoxetine 20 to 80, 40 milligram is average, and similarly citalopram and paroxetine 20 to 50 milligram, 30 milligram is average. Now, dual action of tricyclic antidepressants like amitriptyline and clomipramine have greater efficacy than SSRIs. Individual amitriptyline is more effective than any comparator. Discontinuation of treatment is more with TCAs because of their side effects. These are SNRIs like venlafaxine. And SNRIs are usually kept as second choice when SSRIs they don't work. When we treat depression, we give SSRI. If that doesn't work, if this doesn't work, then we give another SSRI. If that also doesn't work, maybe SNRIs can be tried. If this also doesn't work, then on to tricyclic antidepressants. If the other features are not the ones where it is not preferred, then we give. Okay. Noradrenergic and specific. This mirtazapine is one of the compounds which has its effect on multiple receptors. And it is advantageous in the sense that it is a sedating agent. So a lot of times when mirtazapine is being used, we don't need another hypnotic for sleep. The patient has sleep disturbances also. Sometimes it is also used as adjuvant with other antidepressant with an SSRI to take care of sleep as well as depression, both. Okay. The sexual side effects are also less with mirtazapine. They are not there with mirtazapine. Whereas with SSRI, the sexual side effects are there. So in those cases also, this is preferred. The monoamine oxidase inhibitors, they are not very frequently used. In most of the times, they are the third stage. Okay. Bupropion. Again, bupropion is used when there are sexual side effects or even in retarded depression, patient with hypersomnia, then the non-responders to SSRIs, there these compounds are more favorable. Sometimes patients, when they complain of memory disturbances, pseudodementia, then also these are given. And of course, with sexual dysfunction. Now, imipramine, amitriptyline, usually the dose 150 to 300, but we're not using it very often now, very rarely. These doses I told you, with most of them, okay. The treatment phase, acute treatment is first 8 weeks, then the continuation phase is 6 to 9 months, and then maintenance phase is up to 5 years that goes on. And along with that, supportive psychotherapy, cognitive therapy, interpersonal therapy, that is one of the things which would add to reduction in the dose of maintenance of with antidepressants, and then also when various psychosocial factors are dealt, then further relapse are also reduced. So that's how the psychotherapy is important. If greater than equal to 3 episodes of major depression, then it is almost lifelong, or after every 5 years you try to reduce, because each and every episode when it comes, it becomes more severe, and the suicidal rates also increase. So it's important that you maintain the treatment for a longer duration, for years on, so that person remains well and productive. Okay. Now, here, when patients are diagnosed with major depressive disorder, suicidal tendency, or past history of mania, or present history of psychosis, evidence of severe agitation or retardation, severe physical illness, cause of bereavement in the past 2 months, most of these treat with SSRI. Now, these are various stages of evaluation at 2 weeks, 4 weeks, and 3 months. And you have to see the side effects also, when worsening of symptoms, no clinical improvement or clinical improvement, then accordingly, this is more for the physicians when they refer to the psychiatrist. At 4 weeks also, no clinical improvement, refer to the psychiatrist. There is clinical improvement, continue the drug, same dose. No symptom remission, and continue the drug at same dose for 6 months and see whether remission occurs or not. At 3 months, no improvement, again psychiatrist. Clinical improvement, continue, and then continue drug at same dose for 6 months. When no symptom remission, again continue and see whether remission occurs. Sometimes it is a delayed remission. Educating patient about antidepressants is very important. Unless you educate the patient about antidepressants, they are not going to take it for long. So a lot of times this education, when as a physician, you miss this, and patients, they take treatment maybe for 1 or 2 weeks, and then they feel slightly all right, and then they stop treatment. So education is important, that you have to take on for weeks together or months together. It's not, say for instance, first of all, takes 2 to 8 weeks, to work. Sleep and appetite may improve fast, often help with chronic pain and anxiety. Side effects may occur early on and disappear with time or can be treated. Keep taking the medication even when you feel better. Don't stop the medication before talking with your provider. Primary prevention, secondary prevention, tertiary prevention, all by increasing awareness for 50% of patients who do not reach us, early detection and adequate treatment in secondary prevention, and tertiary by preventing the relapse and decreasing chronicity and rehabilitation. Thank you. In general, whenever you have depression, first of all, never go by words with patient when they say that they have a low mood. You have to inquire more, explore more, whether they are socializing or not, whether all those biological features are present or not, how are the energy levels, how is the sexual drive, then how is the appetite, how is the sleep, whether there are any alterations in these biological features, then whether there are any suicidal ideas or any suicidal attempts which are there. So as a syndrome, you have to check all these. And then duration also. It's not that person has for 2, 3, 4, 5 days and gets diagnosed. It has to be for longer period, 2 weeks at least. And then you treat. When you treat, you let them know that it will take at least few weeks for its effect to occur. Even if it occurs early, within a week also sometimes people respond. Sometimes there are pseudo responses. Pseudo responses are when within 1 or 2 days they come and say that we are feeling all right. So never go by that, and continue treatment for months. So at least that 9 months or 1 year treatment should be given. When it takes few weeks, let the patient be all right and keep on seeing the patient at fortnightly interval or 3 weekly, or even if you are seeing later monthly basis, and then just advise that you continue with the medication. That is the most important thing. They should not stop the medication, because they stop, the relapse is going to happen, and it will be more severe depression and more suicidality. All right, any questions from your side? No, all well understood. Thank you.